I'm pleased to introduce our next two speakers. The first is a friend and colleague of mine, Bill Shuman. Bill did his undergrad at Yale, medical degree at the State University of New York, upstate, residency at the University of Vermont, fellowship in imaging, ultrasound and CT at the University of Washington. One of the things that I'm very, very fortunate is that Bill is also the vice chairman of the Department of Radiology, and he's really transformed it in his 3 years in the department. His research emphasis has been the development and application of advanced imaging techniques, and he's published over 128 articles and chapters related to that. If I had to characterize Bill, he's extremely passionate about everything that he does. And you'll see that reflected in his speech, and you can clearly see it reflected here in a recent fishing trip. The second speaker is Chuck Murry. Chuck is a professor of pathology here at the School of Medicine, Ph.D., M.D. from Duke, residency in pathology at UW, and a fellowship in vascular biology. He's the director of one of the most exciting areas here at the School of Medicine, which is the Center for Cardiovascular Biology and Regenerative Medicine down at South Lake Union. And his research focuses on myocardial infarction and the use of stem cells to improve the heart's ability to heal. He's received some very significant awards already in his career, the Presidential Early Career Award in Science and Engineering, and was twice awarded Outstanding Teacher in Basic Science from UW Med School. Now, I know many of you are missing the Olympics, and we appreciate it. One of the things about Chuck is he actually is also was almost a pioneer in snowboarding. Here he's seen trying to master the single ski technique. You can see it's not working so well, and he realized he needed a wider ski, but in fact he's actually an outstanding skier, so forgive me, Chuck. We're blessed to have two outstanding speakers. Bill?
Thanks, Norm, for that nice introduction. So I'm going to be here talking about CT of the heart and the coronary arteries. And the reason I'm picking this subject in particular is because we have recently here at the University of Washington had the opportunity to install 3 of a brand new level of technology of CT scanners. They're called 64-slice scanners. And to put that in a little bit of perspective, when I started at the University of Washington in 1981, my first task that I was given by the then chairman was to bring CT to Seattle. And we installed a scanner at that time that took 2.5 minutes to do a single slice. And it did a slice that was 1 centimeter thick. By contrast, the machines that we brought online 3 months ago do 64 slices in 0.3 of a second. And so we're producing 192 slices per second, and that's where the technology has gone over the last 25 years. But because of this level of speed, we're now able to freeze motion. And you may have seen on many of Dr. Goldberg's slides that in the beautiful interventional techniques that he does in order to fix problems in the heart is moving at a pretty rapid rate. And so the question becomes, how can we image the heart without putting a catheter in it when it's a fast-moving structure with tiny vessels? Well, as I described in my description of the evolution of the technology of CAT scanning, CT scanning, the change is continuing, and it's at an ever-increasing rate. This is a picture of the current generation of scanners that we're operating with. There's 3 of these operating in the system here now. You'll see it's a fairly typical-looking CT scanner. Here's a patient inside having a cardiac scan done. You notice the tech is kind of blurred in this picture because she's moving quickly. The scan doesn't take very long, and timing is everything with these procedures. Just to give you an idea of what it's like, if I took the cover off the machine, this is what the interior of the machine would look like. And this is how it rotates around the patient. But if I were to do an actual cardiac scan on a patient, just to give you an idea of how quick these scans are and how quick the machine moves, the first thing I do is wind the machine up and get it moving fairly quickly. We inject contrast in a vein, in an arm vein for this, so the injection would begin about at this point. And the actual scan itself lasts 5 seconds. It's 1, 2, 3, 4, 5 seconds. The scan's over, and the machine now slows down and winds down and stops. You've just witnessed the full timing of a cardiac CT. Well, why do we want this scanner? Well, this is what the machine can do. This is not a simulation. This is a real patient. We scanned this patient, their entire heart, their entire aorta, the chest, the abdomen, and the pelvis in 9 seconds, and produced this level of detail of the fine arterial anatomy throughout the entire body. I call these eye-popping, eye-candy images, and they're truly impressive. The diagnostic power is amazing. If we concentrate just on the chest, here's the aorta, and also the coronary arteries you can see as they rotate. This patient we were particularly interested in because they had an anomalous vessel down here, which went into the lung. But you can see the extent of coverage and the detail that's produced, and in this particular case, in 6 seconds. Dr. Goldberg talked about carotid disease in the neck. We know that you get plaque in the neck, and that leads to stroke. But this is the kind of detailed evaluation of small vessels in the neck. The white material you see here is the hard calcified plaque of carotid disease. But we're here tonight to talk about the heart. And the heart is a structure which is unique because the vessels are very small, they're very critical to our happiness and our function, and they move. But this is a patient's heart scanned on our CT scanner here. You can see the tiny coronary vessels coming down here. There's small peripheral branches as they come off the aorta, supplying here the left ventricle, and how they ramify, and even down into their greatest and most inferior extent, you can see the full course of the vessels and how they look in 3D motion. This yellow material here, by the way, is plaque in the coronary artery. So these are really impressive images. These were on Oprah's show about 3 weeks ago, and that resulted in our switchboard being flooded here. But here we see a more traditional way of looking at the vessels. This is the way we look at them diagnostically. You can see the small vessels in the heart and the dense calcified plaque in this patient who has severe 3-vessel plaque disease. I mentioned spatial resolution as a critical factor in the utility of these scanners, and what are we talking about? Well, whereas that first scanner that I mentioned had a slice thickness of 10 millimeters, our current slice thickness is 0.6 of a millimeter. And our resolution now is down to about 0.5 millimeter on a side, if you can imagine a small little box that we can see detailed structures in, and that's what enables us to see these small peripheral vessels in the heart, even though it's a rapidly moving structure. But temporal resolution is perhaps an equally important issue. As I mentioned, we actually rotate around the heart or around the body in 0.3 of a second, but we only need half of that rotation to make the 64 slices, so they're produced in 0.175 seconds. So it takes us only 5 seconds to cover the entire heart while it's beating, and that means the patient only has to hold their breath for about 6 or 7 seconds, and virtually anybody can do that. These machines have bigger detectors in them. The machines that we had just 4 months ago had 20 millimeter detectors in it, and in 5 seconds this is what they could cover. But with the newer machines, with the bigger and more detailed detectors, in 5 seconds we can now get through the whole heart. Well, some patients still can't get these scans, and there aren't very many, but there are some who can't go in the scanner. If you can't hold your breath for 5 seconds, that's a reason why you couldn't get this scan. If you are allergic to the contrast that we give, and a few people are, or if your kidneys are not working well, the material is a little bit toxic to the kidneys, so that would be a contraindication as well. If you have a marked arrhythmia, such as atrial fibrillation or complete heart block, or if you have acute classic cardiac chest pain, that is to say, you've got an acute event, you've got sudden severe onset of chest pain, that's a person having an event that needs Dr. Goldberg's interventional therapy. I don't want them in my scanner, I want them in the emergency room and then in his lab. Before scanning, we need to slow the heart down a bit because even though we're going very fast, the slower the heart goes, the better our images are and the lower the radiation dose to the patient. So we ask the patients to avoid caffeine for about 12 hours, and then we give them a single dose of a drug called metoprolol, which slows the heart rate down. Our goal is to get the heart rate down to about 60 beats per minute, or 1 per second, about 1 hour after the metoprolol, and we do that for a couple of reasons. First of all, it makes better images, but secondly, it's a lower dose for the patient. So how do we do an enhanced CT scan of the heart? Well, first of all, we start the injection, we wait for a period of time, and then we start the scanning. We ask the patient during this time delay to take 3 breaths in and out so they get a bit hyperventilated, and then hold their breath for 5 seconds, and in 5 seconds it's all over. Then when the images go off to a 3D workstation, and this is a dual processor machine, which is able to take 1,500 slices and make a 3D data set out of it, and from that we can actually, with just a few clicks, it's almost become idiot's delight, we can do a coronary angiogram and see the 3 major vessels that are supplying the heart and any of their branches that are larger than 1.5 millimeters. So here's a typical coronary angiogram in a 55-year-old patient who was a marathon runner but who had atypical chest pain, and her doctor wasn't sure whether or not it might be coronary type chest pain, but as you can see, she has a beautiful left anterior descending coronary artery here. She has an exquisite circumflex coronary artery that has no obstruction of any kind. I wish I had one like this. And she has a beautiful right coronary artery, and this is an entirely normal appearance. Now what we like to do is lay these vessels out in a straight line because then we can measure the diameter of the lumen. This is a plot of the actual diameter of the vessel. And we also like to rotate it around. So I look at this vessel from 360 different views. So the vessel rotates around completely, and that way I can see any evident plaque, and it makes it very easy to identify plaque, which may only be seen from 1 or 2 angles as you rotate around the vessel. Remember, this is a 3D data set now, so I can turn it in any orientation. At the 3D workstation, I look at the coronary arteries for stenosis and then for the type of plaque, and we're able to check the rest of the heart at the same time, but also to look at the rest of the chest. So we look at all the non-cardiac structures, such as the mediastinum, the lungs, the pleura, the chest wall, and bones. Remember, for the most part, these are people who are having atypical chest pain. So I can see the whole chest, the lungs, here the heart, the pleura, and even the ribs. We've had a number of patients who've come to us with chest pain, and what they had was rib fracture. But here's a coronary angiogram, and now with a plaque. This is the lesion here. It has some white in it, which is calcium, but it also has some lower density areas, which is the lipid, and you can see it's narrowing the lumen of the pipe here by about 60%. We like to look at such lesions from several different angles to get an assessment of how much the narrowing is occurring in the plumbing of the heart. And again, a case where we are looking at it and rotating around to get a better feel for what the plaque is, how much it's stenosing the vessel, and the character of the plaque. So what's the results from doing this type of a test? Well, for coronary artery stenosis that's greater than 50%, that is to say it's critical, when you compare it to the type of angiograms that Dr. Goldberg does, we have a very good sensitivity for finding plaque. It's about 94%. But perhaps even more important, we have a negative predictive value of 99%. And what that means is if you have a normal CT coronary angiogram, I can tell you with a high degree of confidence that you do not have coronary artery disease and you won't be having any acute cardiac events in the near future. So I've talked about stenosis, narrowing of the coronary arteries, but indeed is stenosis the whole story? Well, stenosis does cause a problem. It causes angina, and angina is due to lack of adequate oxygen supply to portions of the heart because the pipe is being narrowed. But it's probably not the critical issue or the most critical issue in dealing with cardiac disease. Why is that? Well, because about 50% of all of us in this room will die of a first and a sudden cardiac event without heralding angina. This will be an out-of-the-blue event that will kill us on our first heart attack. Why does this occur? Well, it's because we have what's called the vulnerable plaque, and the vulnerable plaque develops acute thrombosis. Acute thrombosis comes in association with a specific type of plaque. And CT provides us the opportunity to visualize the coronary arteries, the vessel wall, and the plaque, and to determine what the plaque is made out of. Atheromatous plaque, that is soft or lipid plaque, has a relatively low density in CT. Fibrous plaque has a somewhat higher density, and calcified plaque has the highest density of all. And CT provides us the opportunity to see the vessel wall in ways that we have never been able to see it before. So I can not only see the lumen of the vessel and see how it's narrowed, but I can also see the plaque that's causing the narrowing, and here, by measuring the density of this plaque, determine that it's primarily caused by lipid. Well, why is that important? Plaque evolves. It's not a static process. It starts out as lipid, and it evolves to fibrous tissue, and then evolves to healed calcified plaque. But it's the early plaque that's the most dangerous. And it's the lipid plaque that can get the acute thrombosis if the fibrous covering over it tears and clot forms on top of the lipid plaque. Lipid plaque is unstable, and it's the early stage of the inflammatory atherosclerosis evolution. By contrast, calcified plaque is stable, and it's the end stage of the inflammatory atherosclerotic process, and it's much less dangerous. When plaque ruptures, that's when the acute coronary syndrome occurs. The fibrous covering on the plaque tears, and you get acute thrombosis that occludes the artery. Most acute coronary syndromes are initiated by sudden thrombosis on mildly stenotic lipid plaques, the vulnerable plaque, and the acute coronary syndrome. And this is the great healthcare event that occurs for many of us in almost the majority of the population. The other thing we're using this scanner for is looking at the whole chest, not merely the heart, in patients who present to the emergency room for chest pain. We call this the triple rule out because these patients might have cardiac disease, but they also might have a blood clot going to their lungs, a pulmonary embolus, or a tear in the large vessel of their chest, the aorta, called an aortic dissection. But remember, chest pain can be caused equally by more mundane conditions such as pneumonia, pericarditis, or rib fracture. And it's the ability of these scanners to very quickly, here in about 7 seconds, cover the entire chest, but yet still have a good adequate spatial and temporal resolution to image the coronary arteries and all the other types of pathology which might be causing chest pain in the emergency room. Here a patient with a very large clot in their pulmonary artery, and here a patient who has a calcified plaque in their coronary artery, but also a tear in the thoracic aorta, a dissection. And so it's the ability of CT to differentiate amongst all these, to find the small plaque or these other causes of chest pain that we believe is going to turn out to be very impactful on the practice of emergency medicine. There are 5 million ER visits per year in the United States for patients with chest pain. And we're investigating the use of the triple rule out CT in the emergency room because imagine the fact that 99% negative predictive value for coronary artery disease, that is to say, if you have a normal CT scan, I can tell you with a high degree of confidence that you don't have coronary artery disease. There's also a high negative predictive value for both dissection and pulmonary embolus. So a substantial portion of these patients, by having a negative CT, may be able to go home safely the same night without a 48-hour period of observation in the hospital and without further tests. And here at the University of Washington, we're investigating, starting last week actually, the impact of this test on that situation. But because these scanners can also very rapidly scan the whole chest, we're looking at another issue, which is the status of bypass grafts. Dr. Goldberg mentioned that one of the ways to get around an obstruction in a coronary artery is to put in either an arterial or a venous bypass graft with a surgical procedure. This is a very commonly done procedure, but the grafts can stenose or occlude over time, and these patients can get recurrent symptoms. Previously, they had to have a catheter angiogram to evaluate their bypass. But bypass grafts move very little, and so they're really excellent candidates for gated cardiac CT to look at the issues of patency or stenosis of the graft. And here's a patient who has a bypass graft going from this artery, which is their subclavian artery of the arm, down through the mediastinum to their coronary artery to provide an alternative pathway for blood supply to the heart. And this particular patient had a very nicely functioning graft. This patient had a graft, a venous graft going from the aorta around the pulmonary artery to their left anterior descending coronary artery, and you can see they've got some focal stenosis or recurrence of stenosis at the anastomosis. So the numbers for graft patency with CT look very good. The sensitivity is in the high 90s, as is the specificity, meaning that this is a reliable test for that application as well. So currently we have fairly good evidence that this is a great test for assessment of atypical chest pain. That is, a patient who presents to a doctor's office with pain that's difficult to figure out. It's not classic cardiac pain, it's not acute, but it's a very common presentation to a physician's office or to an emergency room. For patients with multiple risk factors for coronary artery disease, and they want to know whether or not they have coronary artery disease that needs intensive therapy. For the status of bypass grafts, for the evaluation of congenital heart disease or the repaired heart, and for cardiac tumors. These are good, proven uses for this type of scan. But there are other uses on the horizon. They're under investigation, particularly here at the University of Washington. Chest pain in the emergency room, the triple rule out. Possibly the acute typical cardiac chest pain in high-risk patients may benefit from this test as well. And patients who have had coronary stents and who may be developing stenosis over time can be evaluated with this scanner. We hope to make it idiot-proof in one button, but as the manufacturer pointed out to me, if you do make it idiot-proof, someone's going to invent a better idiot. He was looking right at me when he said that. But the promise of these images is great. We're very excited and feel very fortunate to have 3 of these scanners here at the University of Washington and look forward to them having great impact on patient care and on the investigation of better ways to create health in the heart. Thank you.
Bill, that was fantastic. And as you listen to the lectures that we've had from Dr. Baumstick to Dr. Goldberg to Dr. Shuman, it really talks about the progression of science and how that brings new advances available to our patients today. So, for example, why were we the first place in the world to get these 64-slice scanners? It was because of the science going on here. It was because of our collaboration with cardiology. And in hearing Dr. Murry now speak, I'll just share with you that when I heard he was moving to South Lake Union, I begged for us to be able to put an imaging device there so that we could align what we do with his really cutting-edge science. So.
Great, thanks very much, Norm. And the skiing picture was, I'm really not that good a skier. It was pretty representative, I guess. It's nice to be here. I have the shortest talk of the evening, I think, so I hope we'll finish reasonably close to on time. The last time I was in this room, I think I was proctoring an exam that was almost this full of sweating medical students, and so you all are not putting out nearly the heat, literally and figuratively, that those folks were. So what I'd like to tell you about in the next little bit is the work that my laboratory has been doing, trying to regenerate the heart, which is essentially a holy grail, really, for the field of regenerative medicine that's just trying to get going. Now, you've heard from Steve Goldberg and others that despite advances over the last 50 to 100 years, that heart disease is still a major problem in the United States and other industrialized nations. Heart failure is still the #1 killer in the United States. People who have heart failure get it for a variety of reasons, but far and away, the #1 cause for heart failure is a heart attack or a myocardial infarction. I'll show you an example of this in just a minute, but a myocardial infarction develops when blood flow to the muscle is insufficient to keep up with the muscle's metabolic requirements, and so the tissue is essentially starved to death for lack of oxygenated blood flow. And unfortunately, the heart is about the least regenerative organ in the body, or vying with the brain for that dubious distinction. And so there's really no intrinsic regenerative capacity that the heart has. And instead, what happens after a heart attack, the heart heals by scar formation rather than muscle regeneration. Now, scar can bridge the defect, but it doesn't provide the contractile oomph, really, that's needed to sustain the cardiac output and keep people alive in terms of their blood flow requirements. The only tissue replacement therapy that we have at the moment is heart transplantation, really replacement of the whole organ. We have been flat in terms of the number of heart transplants done in the United States since about 1985. We do about 2,000 a year nationwide. Typically, we do about 40 a year or so in Seattle. Now, we do as many of those as we can. Everybody thinks it's a good idea, but this is completely limited by donor availability, and the best data suggest there's not going to be more hearts available. So what do we do about this epidemic of heart failure that's coming on as the baby boomers age? Well, here's the problem, basically, from a pathologist perspective. This is the disease process that Dr. Shuman was alluding to. This is coronary thrombosis. This is a histological slide, a microscopic image from a patient's coronary artery who died as a result of a heart attack. This region that you see here that I'm outlining should have been a wide open lumen to the coronary artery through which blood should have been passing. This patient had an atherosclerotic plaque, and because it was a vulnerable plaque, it actually ruptured, and you could see that the blood contents became in continuity with the underlying material inside of the plaque. This activates the coagulation system very actively, and this patient's artery became completely occluded, resulted in a myocardial infarction that killed her. Now, the downstream, this is the only gory, I'm a pathologist, this is the only gory pathology picture that I'm going to show you today, I promise. But this is a cross-section through the heart of a patient who died many months after a very severe heart attack. This is the side wall of the heart, the back wall of the left ventricle. You can see the part of the right ventricle over here. And this is the chamber of the left ventricle. Now, it looks, there's something funny going on here. We'll get to that in just a minute. Now, but it looks at first like the ventricular chamber size is pretty normal. But if you follow out the inner layer of the ventricle, it actually comes all the way out like this. And this is a big ventricular aneurysm because what's happened is through a myocardial infarction, all this muscle along the front wall of the heart has been lost, replaced by scar tissue. And instead what's happened is a big blood clot or a thrombus is formed on the lining surface of the heart. And this, unfortunately, is why oftentimes patients who suffer a heart attack have this followed up by a stroke, so a deadly 1-2 punch, because pieces of this thrombus can break off and embolize. So this is the anatomic complication that underlies many patients who have heart failure, the process of their ventricles dilating up and being unable to eject enough blood to sustain the body's requirements. So what can we do to try to do something therapeutically to prevent this process of heart failure after myocardial infarction? For the last decade or so, my laboratory has been studying the ability of stem cells to promote cardiac repair. And you can think of stem cells as falling into two general camps, adult stem cells and embryonic stem cells. And I'll tell you a couple of vignettes about what's going on with the research in each of these areas. Now, adult stem cells are the ones that we're most used to thinking about. They're actually very famous here in Seattle, or Seattle is famous for them, because this is really the place that puts stem cell-based therapies on the map. Through work done at the University of Washington at the Fred Hutchinson, bone marrow transplants, which are essentially the first stem cell-based treatments, were developed and are now used to save the lives of approximately 50,000 people a year worldwide. So kudos to Seattle for having developed that. Now, the reason this works, of course, is that tissues in the body that turn over normally, our blood cells do, our skin cells do, the linings of our intestines and so forth, have to have a population of cells that are capable of restoring them or maintaining them afterwards. And this is the job of the adult stem cell. We know the most about the adult stem cells in the bone marrow, where a primitive stem cell lives that can give rise to various kinds of white blood cells, red blood cells, platelets, and things like that. One of the questions that came up in the latter part of the 1990s was maybe these adult stem cells are more plastic than we originally imagined. They weren't so restricted in their repertoire, and perhaps circulating stem cells might be able to give rise to things in addition to just blood cells, like heart muscle, for example. Well, we tested this in a variety of animal models, but I think the most interesting work really came out of studying people. And so this was a study where we looked at patients who had undergone cardiac transplantation. And the patients that we chose were a very special subpopulation. They were men who received hearts from women. Now, I don't know whether this made them stop and ask for directions or quit watching professional wrestling. I leave this to the sociologists to comment upon. Maybe Pepper Schwartz will come next time and discuss that aspect. But what it does, when you have a girl heart in a boy body, it allows you to use the Y chromosome to track the cells that didn't come in with the heart initially, but came in through the circulation. And then you can use other techniques to find out what the identities of these cells are, and it gives you a very unique way to track the events. We think the same processes probably go on in other heart transplants or in many other areas of injury and repair throughout the body, but this is a very specialized circumstance that allows us to track the events in people. So the hypothesis was that there would be circulating cells in these patients that would give rise to new cells in the heart after transplantation. This slide is essentially one-stop shopping that shows the results from this experiment. We used a special stain that identified blood vessels in red, and then we used a probe that identified cells that contained a Y chromosome in green. So here in the cells lining this particular blood vessel, you can see there's one, here's a second, and here's a third blood vessel lining cell. They're called endothelial cells that contain a Y chromosome inside this female heart. So clearly these cells did not come from this heart originally. They must have gotten there somehow, most likely through the circulation. Now over here, these big green log-shaped cells with these cross striations are the heart muscle cells. This is the nucleus of a heart muscle cell in blue, and this little green dot in it is that troublesome little Y chromosome that causes all these troubles in the world. And this is a heart muscle cell that has a Y chromosome in it. What I can tell you is that this was an extremely common event. We can find 3 such examples in a single blood vessel. This is an extremely rare event. We had to search and search and search to be able to find a representative example. If we do counts to see how well different cell populations in the heart are able to be repopulated by circulating progenitors, it turns out that the cells that line the blood vessels are really quite common. Almost 25% of the cells in a patient's heart after transplantation in the vascular compartment seem to be derived from these circulating progenitor cells. And this is an unexpected phenomenon and maybe of fundamental importance. Interestingly, about 10% of the cells that line the nerves in the heart, they're called Schwann cells, seem to be derived from the circulation. Smooth muscle cells in the arteries are getting into the act, well, about 3%. And way down here are the heart muscle cells. And these are the ones that we would like to have in terms of restoring pump function. It's not 0, but you have to use an entirely different scale to show it. It's about 0.04%. In other words, 4 out of 10,000 cells seem to be repopulating from these circulating progenitor cells in the adult. What we conclude from this human experiment, if you will, and many other experiments that we've done in a variety of animal models, is that adult stem cells seem to have a remarkable ability to give rise to new blood vessel cells. And I think in terms of trying to do revascularization approaches, inducing sort of natural coronary bypass mechanisms with adult stem cells, this holds great promise. Conversely, we're not too optimistic about the ability of adult stem cells to remuscularize the heart, to actually grow back new muscle cells. No matter what we've tried, we keep getting the same answer, that again and again, the adult stem cells seem unable to grow new heart muscle cells. Doesn't mean it can't be done, it just means that nobody seems to know how to do it at this point. So I'd contrast adult stem cells then with embryonic stem cells, and in contrast to the relatively restricted ability of adult stem cells to turn into different cell types, embryonic stem cells have an unrestricted ability. They can virtually become any cell type in the body. This includes heart muscle cells, I'll show you that in just a minute, and also insulin-producing cells that might be useful for treating patients with diabetes, for example. These are 2 cell types that are very difficult to get from adult stem cells. They have a tremendous capacity for cell division, so that one could imagine growing up large vats of these really for therapeutic quantities. And I think they offer the ability to teach us fundamental lessons about how we develop as human beings, and also potentially down the road as disease therapeutics. So for this reason, people who do the practice of regenerative medicine research are very excited about embryonic stem cells. Let me tell you about where they come from. They've been much in the news lately, and they're often a very misunderstood cell population. There's been a lot of political rancor, unfortunately, about this particular cell population. Now, everybody in the room started out life at this stage. We were all fertilized eggs, or a zygote, as it's known. It sits in this protective coating. It's kind of like an eggshell that's called a zona pellucida. This single cell starts to divide and forms a solid ball of cell, and that's called a morula. And the morula goes on to divide to form this hollow ball of cells that's called a blastocyst. There's a little bit of specialization in the blastocyst. It still has this shell around it. It's got this outer layer of cells that are called the trophoectoderm, and that's what's going to give rise to the placenta and to the amniotic membranes. And then here in the inner region is a specialized set of cells called the inner cell mass. And these are the cells that are actually going to give rise to all the tissues of the embryo. And so this, in terms of normal development, would be at about the 5-day-old embryo. It would still be living in the fallopian tube where fertilization takes place, would not have implanted yet in the wall of the uterus. So this is what's been used in vitro fertilization clinics. When IVF is done, blastocysts are generated by growth in a petri dish, and then they're either implanted directly into patients or they're stored frozen for subsequent rounds of attempted impregnation. So if one takes the inner cell mass and derives cultures from them, you can actually develop embryonic stem cells. I just want to give you a sense of it looks big when it's up here on the screen like this, but just let me give you a sense of the scale of what we're talking about for human development. This is an electron microscopic picture of the head of a pin. And this is the size of a human blastocyst in comparison to the size of the head of a pin. Now, it would be insulting to your intelligence to say that because something is small, it's not important. Obviously, that's not the case. Speaking as a former blastocyst, I would object to that. But this is it's a highly specialized and an absolutely remarkable tissue, but I believe it deserves further study as something because of the tremendous good it has the capacity to do. What I'd like to do is show you a little movie about what can be done with these cells. So this is a movie that shows what we've been able to do with embryonic stem cells, where we've induced them using some tricks from developmental biology to form beating human heart muscle. What you're seeing here are areas of the pointer's not showing, but you're seeing individually contracting human cardiac muscle cells that we're growing in a petri dish, and you can cruise around the petri dish and just see that there's lots and lots of beating activity. To me, I sit and I look at this stuff beating in the dish, and then I know there are patients who are dying of heart failure, and I think we can do something about it. They sometimes make these little beating structures that we call cardio balls, and every time they twitch like this, we know it's because they have a burst of calcium that's released intracellularly. And so calcium is the trigger for contraction, and we can use special imaging techniques. So there you see it flashing. Every time it beats, it's accompanied by a flash of calcium fluorescence under these specialized ultraviolet imaging optics that we're able to do. So you can see, each beat, poof, there's a flash of calcium that's inducing it. So this is the stem cell biologist's view of a gift from Mother Nature. I think the hard part has been done for us, and this is something that if we can just take this, grow it in the hearts of people who have heart failure, we could be doing a lot for people who are suffering. So to that end, if we could bring the lights back up, please. We've been able to take the heart muscle cells that are derived from these human embryonic stem cells beating in a dish, as I've shown you, and we've begun transplantation experiments into experimental animals. We've done a special stain. This is a microscopic picture, and what you see here in this dark red stain is a graft of human cardiac muscle. It's survived for 4 weeks in this experimental animal's heart, and it's actually, interestingly, started to proliferate. This brown stain in the nucleus is a dye that we've put into that's incorporated in cells whose DNA is being elongated. And this is a cell that's in mitosis. And so they survive and they actually proliferate and grow 7 or 10 times bigger than they were than the original implants were. And so this suggests to us that you could probably implant a subtherapeutic dose of cells, have them grow over time to give perhaps a therapeutic benefit and regenerate a patient's heart. So how would we test for efficacy? Well, I showed you the echocardiogram of a patient's heart. Because engineers are engineers, they always build a lot of excess capacity into all their systems, bless their hearts. And as a result, if you use the pediatric ultrasound systems, you can actually get very good images of rat hearts. And so this is a rat heart that's functioning normally. The rat's head would be over on this side. The rat's tail would be over on this side. Rat heart beats about 300, 400 times a minute, so it's very rapid. But you can see the same kinds of thing. Here's the wall in the front, the wall in the back, and this black space is the blood that's in the chamber getting ejected with each beat. Here's a rat that's had an experimental heart attack or myocardial infarction. And you can see that the black area is much bigger. This is because the heart is dilated up, just like people's hearts do after a myocardial infarction. It's contracting much, much more sluggishly. And so we're able to use these as measuring tools to determine the function of the hearts after an experimental heart attack to see whether a therapy that we're doing has any positive benefit. This is the early days. We're just getting going at this, but even at this point, we're having the first hints at effectiveness. You can see that these are the animals that were treated with a placebo, and these are the animals that were, excuse me, I've got it backwards. The black bars show the animals that were treated with stem cells. The gray bars show the animals that were treated with a placebo. And at 1 week, we could not tell a difference in them, but at 4 weeks after treatment, the hearts of the animals that received the placebo treatment had continued to dilate up, and that was attenuated by the embryonic stem cell-derived heart muscle implantation. It's a modest benefit, I'll grant you that, but it's the first hints we have that we're actually beginning to, by growing back human heart muscle in these experimental animals, have some therapeutic benefit. Now, whenever possible in doing stem cell research, we try to take lessons from Mother Nature, and really the best teacher in this regard is the embryo. And so what I'd like to do, since I'm an experimentalist, we have an experiment that we're going to go live with here in the classroom. Over to my right is Dr. Lil Pabon, who is a card-carrying developmental biologist who got her Ph.D. doing chick embryology work. And Lil has graciously put together a collection of chick embryos so that we can demonstrate to you the cardiac anatomy as it goes from very rudimentary stages to much more advanced stages. And we try to use the embryo as the teacher, really, to tell us how to, if we want to grow back heart muscle, we need to learn how it grew in the first place, essentially. So if we could flip the switch to go onto the microscope.
Okay, what you can see here is an embryo that has been developing for 2 days. And what I want to highlight at this point is the fact that you have a primitive heart tube that has already formed. And the way this heart tube forms is you have cells that are each side of the embryo. They migrate to midline and form a tube. And then what you can see is the very beginning of looping. Looping is very important because due to looping, this heart eventually is going to form a 4-chamber heart. What you're going to see in the next stage, which unfortunately has fallen apart a little bit in transport, but we'll do what we can, is only 1 day after the embryo that you just saw. So this is after 3 days of development. So you can tell that a lot has happened in this 1 day. Basically, you can see very obvious vasculature. The embryo has started to turn. Now you see that the head is a lot better formed, and you can see actually the pumping of the heart that is occurring. So you have a lot of morphological changes that are happening very quickly. Then you go from this stage of development, which is only 3 days, to a stage where you can actually start distinguishing something like the heart that we all know and love. So this is only 3 days after the previous stage I showed you. And what happened in those 3 days is that you have a layer of cells that started off as a little group of cells at the bottom of the heart tube, migrated over the heart and formed the epicardial layer. Then some cells undergo a cellular transformation and dive into the heart, form the vasculature of the heart, and the epicardium itself starts pumping factors towards the myocytes until them grow, proliferate. And then you get a big burst of proliferation that is occurring, where you will see between the heart that I have now and the following heart is only 5 days of development. So you can see what I mean by we have a very big burst of proliferation that occurs in this very narrow window of time. So in relation to what Chuck was telling you, what we're trying to do is take some of the insights that we have gained from model systems like the chick and apply this knowledge to the characterization of the mechanisms that might control the development of the human cardiomyocytes.
Good. Thank you, Lo. So just to complete things, this is not just something that's going on in experimental animals. Cell-based cardiac repair is actually undergoing clinical trials across the world, including in the United States. What we know now is that multiple phase 1 trials have been completed. Phase 1 really means, is it feasible and is it safe? And the first populations of cells that people have checked out have been skeletal muscle cells and bone marrow cells. What we've learned from these phase 1 studies is that it's quite feasible and it's mostly safe. The most feared complication was that patients might grow tumors of some sort in their heart. This has not been the case for either cell type that's been tested at this point. Skeletal muscle implants have resulted in some patients having arrhythmias, and patients are now getting defibrillators implanted along with their skeletal muscle grafts to see whether this is necessary. The studies were never really designed to show effectiveness, but they at least offer some tantalizing hints that patients might be benefiting from these. But again, as we heard before, it's important to have randomized controlled trials for this. These are currently getting underway both in the United States, Europe, and in multiple places in Asia as well. And I think these are going to be first-generation kinds of things where they're from the patient. They're what we'd call autologous transplants, patients' own bone marrow, patients' own skeletal muscle cells. Later generations will probably use more of a universally engineered donor cell. So the thoughts I guess I'd like to leave you with on this is that stem cell research really offers the chance to rebuild damaged tissues from their component parts. And for me, this is one of the most exciting things that's happened, and I hope that, you know, looking onto the next 100 years, this may be the equivalent of the discovery of antibiotics. Adult stem cells are going to be very useful, there's no doubt, but they're clearly more limited in the kinds of tissues that they can turn into. Embryonic stem cells are clearly not limited in the cell types that they can become. Now, the other side of the coin is that with this greater plasticity comes greater danger as well, and we know, for example, that it's possible to generate tumors if one does not use embryonic stem cells judiciously. The research into human embryonic stem cells has slowed markedly compared to what it might have been because of the political and ethical concerns on it. And at the moment, it's legal to do any kind of human embryonic stem cell research in the United States, but federal funds can only be used for stem cells that were created prior to August 9th, 2001. My personal opinion, and this is simply an editorial comment, I've labeled it as such, is that if we want stem cell research to be done in an ethical way, it needs to be done transparently and with public oversight. And the way that that happens is through public funding, not by pushing it off into the private sector. Thanks very much.
Dr. Bomstick, Dr. Goldberg, Dr. Shuman, Dr. Murry, and Dr. Murray's colleague. That was most excellent. So please, one at a time, come up to the microphones and ask our panelists, Dr. Bomstick and Dr. Goldberg and Dr. Shuman. And the people who photographed this marvelous endeavor would like you all to stand together.
Yes, question here, please.
I have a question about any person that's having cardiac distress. What is the best way to access care in the emergency room? What should you tell the physician? What information should you have coming in? When should you go? Essentially, there's a lot of people that come to the emergency room and feel like they're sitting in the waiting room for a long time trying to access care. And I was just wondering how to bypass that loop to get the care that some people need.
If you tell them that you have a respiratory complaint or are having chest pain, that makes you a level 2 patient, and our goal is to bring you back within 10 minutes and do an electrocardiogram on you. We just make sure that you're really having the chest pain. But again, chest pain, sudden neurological event, sudden shortness of breath is a category level 2 patient, which means they need to be seen no matter how busy the department is. We have to shuffle patients around to open up a room to see those people.
Thank you.
Hi, I have two questions. For Dr. Goldberg, the double umbrella, what's the material, the white material, and is there any reason for danger from rejection?
The material is made out of the skeleton that you could see on the x-ray is stainless steel, which is used in a lot of medical products like the stents are stainless steel. And the tissue over it is polyester, which is also used in other medical products. We haven't seen any problems with rejection of this device. It gets scarred over quite nicely, and so that doesn't seem to be a problem. Interestingly, the other device, which I didn't show you, which I forgot simply, is a device that is made, I think if you see two discs, it's made out of nitinol, a special metal. And both nitinol and stainless steel have nickel in them. And a fair number of women have nickel allergies that they get with their earrings. And so, yet we don't find that this creates any problem whatsoever. We've actually put these in people with known nickel allergies, and they don't seem to have any adverse effects from it.
And my second question is for Dr. Shuman. Is the 64-slice CT appropriate as a tool for preventive diagnostic testing? If you don't have any symptoms, can I go in and say, I'd like the whole shebang, tell me what I'm going to get? And how much would that cost me?
Yeah, I agree. Oprah would say yes. In the heart, if you have multiple risk factors, that's a good reason to find out the status of your coronary arteries. In other words, you have early coronary artery disease in your family, you run high lipids, you're diabetic, you're hypertensive, those kinds of issues. With multiple risk factors, that alone is a good reason to evaluate your coronary arteries. In the rest of the body, there's a lot of research going on as to whether or not we should be using these scanners just to look for disease in people who are otherwise healthy. So far, the preliminary data suggests that it causes more trouble than it solves in many instances, because what you do is you find findings that are benign findings, but they need further evaluation to, little spots in the lung, for example. We don't know what they are, but we have to either do multiple scans to see if they're growing, or do limited surgery to take them out, or biopsy them, and those all have complications. So the question is, do you do more good than harm in healthy patients by scanning them? And I think the answer is going to be it's not worth doing, but again, the data is not completely in on that yet.
Thank you.
I have a question for Dr. Murry. You said that we are only allowed to do stem cell research on currently existing cell lines. First of all, where do those cell lines come from? And second of all, are there limitations to being limited to only those cell lines versus being able to create your own blastocyst cell lines that way?
So the research that we can do research on any stem cell lines that we like, but we're not allowed to spend federal money. Now, my laboratory has 80% of its funding from the federal government, and so this presents a real problem for me. If I wish to study these other cell populations, it's very difficult to do so. So where they came from was in vitro fertilization clinics. Throughout the world, a number of these were originally, the clinics were located in Israel. The cells were isolated in Wisconsin, at the University of Wisconsin. That's where the first lines came from. Others came from Australia, Singapore, and things like that. So they're from all over the place. But at the moment, there are only 22 cell lines that are available for study with federal government funding. And we feel, and unfortunately what we find is that over time they lose important properties like their ability to form heart muscle. They're not as inexhaustible as we would like at this point. And so the cells that we have also been contaminated by exposure to mouse cells and may not be suitable for transplantation applications. So we feel like we've had a good 6 years in terms of learning how to use them, but those of us doing research in the field would really like to see the handcuffs taken off so that we could do the most innovative research.
Okay, thank you.
Sure.
I have a question for Dr. Goldberg about people who have PFOs that don't close, as they normally should when they're 2 years old, like you said. For people who get strokes due to that, the PFO being present, do we know what age they usually get the strokes at?
It's a good question. I've closed PFOs in people ranging from 16 to 86. So it's an all range, for people with strokes, that is. So I can't tell you exactly where that's that's going to play out. We know that as you get older, that is over age 60, there's a lot of other reasons for strokes, so it's a little bit difficult to separate out the relative importance of this mechanism because of other reasons, such as buildup of plaque in the arteries. But it's a great question to understand that we don't understand at this point, the age relationship.
Okay. So for younger people, I would imagine that's usually when they find out that they have a PFO.
Yes, yes. And that is usually the case. For that matter, for any age, we don't go looking for the PFO unless there's reason to, because 20% of the population, or 25 to 50 million Americans, are running around with PFOs. Yeah. So if we went looking for them in everybody, then we'd be opening up a whole other can of worms, like Dr. Shuman was alluding to. And of course, if I start closing all the PFOs in 25 million Americans, I'd have a nice newer car. Yeah. But I'm not sure there's much other benefit.
Yeah. And one more quick, the study that you mentioned with the sham surgery, is that ongoing?
No, that has been completed, but we don't have the results yet, and that was in England. There are studies that are being started in this country that are ongoing, and we'll be having part of one right now. Most of the holdup has to do with FDA kind of negotiating with the companies as to how to design these studies. They're fairly tricky to design, actually, because of the fact that because the endpoints have to do with pain, which is subjective. So designing studies that makes them as objective as possible is actually quite challenging.
Yeah. Thank you.
Sure.
Hi. Yeah, my question is for Dr. Goldberg too, and it's about the PFO, about the association between migraine and PFO. So there is genetic factor in migraine. So do we know if there's genetic play a role in the PFO formation too?
Yes, and that's a great question. And in patients with migraines who have PFOs, then there is a familial relationship there. I have a patient of or a family whereby I've closed the PFO in the 18-year-old girl who had a stroke and had migraines, in the 42-year-old father who had 2 strokes and had migraines, and the 19-year-old son has migraines and a PFO but hasn't had a stroke. And it is an interesting situation that there is a strong familial relationship, particularly when you find migraines and PFOs together. They do tend to run in families. All right.
Thanks, everybody.
Thank you.